but it's really a separate disorder, completely separate than your mobility. It's related to immunity, and you will have much better understanding at the end of our discussion about what that is. Okay, and so this is a little background. So let's start with the fractures first, because it's a relatively easier to understand, I think, because you all have some degree of knowledge about what fractures is. At least everybody knows it's a breakage of bone. And here is a little picture, although it's a little scary, but really presents all the 206 bones that we have in the body after fusion in the adult life. And as you can imagine, any of these bones can break to any degree. And the treatment will depend on the type of breakage, the bone, the person, the comorbidities, and all that. Okay, so let's get started with this little background information that we have here. And anytime if you have trouble hearing me or anything, you can't see what's being presented, please tell me, put in the chats or unmute yourself. And so etiology is the cause, right? Etiology, it's a cause. So the simple cause is that when when the force, just a second. Okay, there's two types of forces. The force of the bone, which is the strength of the bone, and a force that is coming from outside, that is being exerted from outside. So when the force of the bone is more than the force exerted from outside, it's gonna not break. Okay, it's gonna resist all the breakage. But if the force coming from outside, which can be of any nature, we will discuss, and if that is more than what the bone can handle, then it will break. Then it will cause a fracture. Okay, that's basically what it says. Force can be of any nature. It can be compression, twisting, repetitive small forces on the bone, and we'll discuss about it. Single force, immediate force, you fall on something and you fall on ground, immediate force that will fracture the bone at the point of impact. Okay, and yeah, and the small repetitive forces that will break the bone at the weakest point. So for example, patient has osteoporosis, and a lot of it, actually it will be easy for you to understand because you have a lot of basic background information at this point, right? You are not new to all this information on infection and osteoporosis, bone, the knee surgeries, so the replacement surgeries. So you have a lot of background information on it, which I'm happy about because it will be easier for you to understand. For example, osteoporosis, the bone is weak, there is less calcium. So now the little compression force that is being exerted from day-to-day daily activities on the bone, that will break the bone at the weakest point. So this is really etiology and the cause of the bone breakage. Now, type of fracture. This, I took the picture, I took directly from your book itself. And these are not related to each other. The type, these are not like opposite of each other. All these are kind of independent. Some of it are, you can remember it as being opposite to each other. For example, closed fracture. First is closed fracture. As the name itself is suggesting, there is a break in the bone. Here is a little break in the bone, but the skin is not open yet. Okay, skin is not open yet, which we see all the time, and that is also called a simple fracture or closed fracture. Open fracture, as you can imagine, the bone is broken and it's protruding out of the skin now. The skin, the dermis, epidermis, subcutaneous fat, everything is invaded and everything is open. We see the bone and the bone marrow. This is also called a compound fracture. And as you can imagine, patient will be more at risk of osteomyelitis, which is the bone infection, because now the bone is exposed. Complete fracture is here. The whole bone is kind of cut through. Okay, it's a complete fracture. Green stick fracture, very commonly seen in children, and it means that a bone is broken at some point, but not completely. It's not complete. At a little point here, bone is still joined. Again, the treatment will be different for different type of fractures, as you can imagine. Comminuted fracture. Comminuted is that bone is broken into multiple fragments. It all depends on the person, on the nature of the force, accident, fall, whatever happens. And so it's now broken into multiple different small, tiny pieces. Impacted fracture. In impacted fracture, which is also called a buccal fracture, what happens is there is a bone on this side, there is a bone on this side, right? Ideally, there is a joint, right? That's how bones are joined. So what happens is because of the force from both sides, they kind of invade each other. They merge into each other, right? And this is called a buccal fracture, as you can see here. And children's arm and in hip it's seen a lot. So buccal fracture, impacted fracture, bones kind of get pushed into each other. Oblique fracture is like in the bone, it's oblique, right? The shape is oblique. Transverse is completely vertical. Linear is horizontal, parallel with the bone. Very easy to understand. Displaced fracture. So in displaced fracture, what happens is there is a bone here, there is a bone here, and now the bone has displaced from its alignment. Okay, I mean there was a single bone, and now it's broken, and it is displaced from its alignment to one side. Non-displaced fracture is that it is not displaced. I mean, some of the terminologies are just so simple. Just by reading, you can get information. It's not displaced. Avulsion fracture, what happens is now the bone is separated from the rest of the bone and it's totally displaced. Okay. So, for example, this is a bone, a part of it is broken and has gone into the soft tissue, somewhere, right? Stress fracture. Um, what is a soft tissue? We talk a lot about soft tissue. There is a soft tissue infection. Bone goes into the soft tissue. What exactly is soft tissue? Fat, okay, muscle. What else? Right? Soft tissue. We talk a lot about it. Skin might not be. Vessels. Okay. Yeah, yeah. Good job. We are completing what I'm asking. Not cartilage, nerves, connective tissue. Yeah. So basically everything that you're writing there is right, right? That's a soft tissue. So whenever we say soft tissue infection can happen, the bone goes into the soft tissue. So anything, the name is itself signifying everything. Soft tissue is soft. Bones are not soft. Those are hard tissue. Cartilage is not soft. It's a hard tissue. Soft tissue is skin, vessels, nerve, tendon, ligament, right? The connective tissue, nerves, this everything is soft tissue. All the organs are surrounded by soft tissue just for a little bit extra support, right? What is a tendon, right? We should have a little background information as well. What is a tendon? Muscle connects to bone. Yes, muscle connects to bone. There you go. Okay, you have that. So tendon is a fibrous connective tissue which connects bone to the muscle. And ligament is opposite to that. It's a fibrous connective, soft connective tissue which connects bone to bone. Remember tender chicken leg. Okay, yeah, that's great. Yeah, my mnemonics are a little bit weird. I remember LB, bone, ligament, bone, but I think this is better. And so this is good. So this is connective tissue, right? Very good. Stress. So stress fracture is repetitive forces. Again, the muscle is already it, for example, in continuous pressure exerted in sports or exercise, so continuous force is putting stress on the bone, and that's how it gets fractured. Spiral fracture is im- important as well. And as you can imagine, as it's shown here, it's the shape of spiral that it gets broken. And although in abuse, children abuse, fracture can be of any type, but spiral fracture especially is a big red flag if kids come with that, because if holding by the arm, or the twisting the arm, which is seen in children abuse, spiral fracture can happen. So, and commonly occurs in children anyways, it says here. Depression is a little depression because of the force in the skull. Mainly it happens. That's a compression fracture. Pathological is you already have a disease like cancer or osteogenesis imperfecta. It says it's really a genetic disorder, which is also called a brittle bone disease. It's genetic, seen in the kids, and bones are very brittle and very easily, like literally getting out of the bed, walking, simple movement, day-to-day movement can cause in the breakage of the bone. In adults, it can be bone cancer and osteoporosis and things like that. Compression fracture. Compression also can be seen in osteoporosis, especially in the spine. There is a force exerting from both sides, and it can cause a lot of force on this vertebrae, and there can be a compression fracture, and patient will go for surgery for that. So these are some type of fractures. And now fracture healing, as I have mentioned a lot of times earlier, that our body wants to maintain the equilibrium. For example, in hypothermia, in hormonal metabolism, everywhere we studied about positive, negative feedback system, homeostasis we studied about. Similarly, our body, whether we are in good health or not, at least will try to heal that fractured bone, okay? It will try. That's why we see the splints, the casts, the slings. Not every fracture needs to go through surgery, right? We try to just immobilize the area so that it can heal by itself. So there is three phases of healing. The first is inflammatory phase, the second is a reparative phase, and third is a remodeling phase, okay? And by this help of this picture, I'm gonna try to explain that to you. And so pay attention to that, right? And so first what happens is that there is a break in the bone, as you can see here, there's a break in the bone. And so and I have a little here plus sign, this arrow, that is it's this cursor. Even if I don't draw on the picture, do you still see the cursor moving around? I just want to make sure that you're following. Oh, you don't. Okay. All right. That's good to know. Okay. Thank you. And just the marker. How about now? Do you see the blue cursor that I have now? Okay. All right. Thank you. Thank you. And okay, so I'll go with that. So first phase is here. If you look here, this is the first phase. In this, what happens is there is a breakage, and as you can imagine, whenever there is a breakage, all our soldiers, which I always say, the WBCs, right? The types of WBCs, the immune cells, the lymph itself, it will try to mobilize every resource to that area, right? So it mobilize everything there, and it starts to form a lot of extra blood vessels at the site of the injury. Why the body starts to make blood vessels around the site of the injury? What is body trying to do? Yeah, it is trying to oxygenate. There you go. Yeah, that's where I was at. It's trying to oxygenate. It's trying to provide nutrients to that part, right? So when there is extra capillaries, extra blood vessels, as you can imagine, it's going to be inflammation, it's going to be swelling, little bleeding, and hematoma will be formed, okay? This is the first stage, which is inflammatory phase. So all the inflammation is happening. The second phase, what happens is the fibroblast, now it is gonna try to form a woven bone. Woven bone, as you can imagine, it is a soft callus. It's also called a soft callus. So it will try to make a soft callus on it, which can take like 2, 3, 4 weeks depending on the person. So here it's trying to kind of make a soft callus, which in which fibroblast, osteoclast, chondroblast. I know these are probably you have heard these terms in your anatomy class. Basically, these are the cells that form that you don't have to remember, all the names, but just have basic understanding that these are the cells that form the connective tissue. These are the cells that form the bone. So these cells start to form here, which is going to start to create a soft bone. And then minerals come in there, right? Calcium, phosphorus, and vitamin D, right? These are the main minerals, blast building cells. Yeah, these are the main minerals in the bone, okay? So this soft callus will slowly get hard, and that will create a hard callus, which is pretty much a bone, and then it will become a bone. So this is like kind of a little, healing process that happens. If the healing does not happen, then it can cause in these three things delayed union. Delayed union is depending on the person, a healthy person, you are thinking maybe in 1 week the bone will get healed, or it's a simple fracture. But it took now 4 weeks, it took like 2 months or 3 months. This is a delayed union. Anything that takes more than 3 months, that is non-union, no signs of healing. Actually, I should say it shows no signs of healing on an X-ray, on CT, MRI, whatever test they choose for at least 3 months. That's non-union. Okay, that means the body is not completely in a healthy state, I want to say, physically, mentally, or psychologically, however you want to say it. Malunion, it did a good job with healing, and it kind of displaced. There is still bone fragment, it's displaced, and the whole bone is not reformed. Okay, so that's kind of pathophysiology. Risk factors are very simple. Young children can get more fractures because of just the energy. There's so much energy constantly falling down, and older people can have falls. They have comorbidities, osteogenesis imperfecta, brittle bone disease. It's also called brittle bone disease, bone cancer, poor nutrition, and lifestyle habits, dangerous participation in, like, sports or dangerous activities. I want to say that can put you just at general at more risk for getting fracture. Clinical manifestation, again, very, as you can imagine, what would be the clinical manifestation. Sometimes actually you have to think just would require surgery. Yeah, Erin, and absolutely. Depending on the type of malunion, right? That's a good question. Depending on the type of malunion, it might require surgery. Okay. And if it's a lot of, displacement from what was required, they might go for it. And when I talk about surgery, you'll have better understanding. And if it's a little bit, we may just immobilize the area, do some other treatment, which we'll talk about. That's a good question. And a clinical manifestation, as you can imagine, they will have pain. They will have on x-ray, you will see the visible fracture, visible deformity, swelling, numbness. Numbness happen because of the injury to the nerves. Internal, external loss of blood, right? Patient can go into hypovolemic shock, right? And you guys are good with the shock. You already know background on that as well. Crepitus. What is crepitus? Cracking. Okay. Grinding bones. There you go. Yeah. And that's a sound of grating of the bones with each other. Okay. Which is one other condition, if somebody has seen that or know that, where crepitus can happen. One of very commonly seen in, yeah, not related to bones, not related to mobility, some other system where crepitus happens. It's probably you haven't studied about it yet. And but in the lungs, if there is a leak in the lungs, and yeah, there you go, and the air gets trapped in the soft tissues, especially around the collarbone, and it's so when you press on the collarbone on the soft tissue, it will make sound of popping, popping sound, actually, like popcorns or crackling sound when you just touch the soft tissue. That also crepitus is seen in those cases. People with chest tubes, pneumothorax, and injury to the lungs, and this crepitus is very common in them. But basically, here we are talking about grating of bones. Okay, let's study about complications, and these are important. Okay, complications of fractures, or what can happen. The first one is compartment syndrome. You may have heard of this term before, I'm not sure. But compartment syndrome, what that is whenever we dissect anything horizontally, for example, I'm dissecting, say, thigh, all right? Anybody's thigh, we are dissecting horizontally. Obviously, we are going to have muscle, bone, ligament, and everything there, right? Or the connective tissue, everything. But these are divided into compartments. Sometimes there is a anterior compartment, there is a posterior compartment, there is lateral compartment, middle compartment, things like that. So one compartment is comprised of a muscle, nerve, blood vessel, connective tissue, all that, everything that you already have a good background information. And that's one compartment. So in compartment syndrome, what happens is too much pressure, too much pressure in one particular compartment, it will cause everything that's in that compartment to kind of get pressurized, lack of blood supply. And what happens at the end of the lack of blood supply? Now there's pressure, no blood supply. What's going to happen? Extreme ischemia. That's where I was coming at. Tissue death. Yeah. Tissue death, ischemia, necrosis. Okay. Basically, that is compartment syndrome. Right? There's a lot of confusion about it, but basically, that's what it is. And fractures can lead to compartment syndrome. Okay. Whenever there is a fracture, there is inflammation. There is a lot of phenomena that's going on with the blood vessels, everything. It starts to put pressure in the compartments, and then the soft tissue there starts to die. Okay. That's compartment syndrome. Having said that, also, when sometimes we put cast to immobilize the area, that can put pressure as well, and that can cause compartment syndrome as well. Basically, it's an emergency. Whenever we see the sign and symptoms of compartment syndrome, it's an emergent surgery that patient has to go for, fasciotomy, or just to relieve the pressure. So that's all the information that I have here, and you should be able to follow now. The edema, swelling, decreased blood supply, nerve damage. Symptoms are pain, tenderness, swelling, paresthesia. What is paresthesia? You might have heard of this thing. Tingling, numbness. Yeah, absolutely. Yeah, and tingling and numbness, right? Pallor. What is pallor? Pale. Okay, pale. Loss of blood supply. Numbness, decreased absent pulses. And poikilothermia. What is poikilothermia? Poikilothermia, yeah, okay, thanks for sharing. And poikilothermia is poikilothermia is the body's inability to regulate temperature. Okay, that's basically. So at the point of injury, compartment syndrome, obviously, because of lack of blood supply and the heat conduction, convection, all that good stuff that we studied about. So body is not able to regulate the temperature. So it's going to be pretty much cold. The affected extremity. Okay, this is very important, these symptoms. Why? It guides your assessment, it guides your nursing assessment that you're going to perform on the patient. And most commonly lower leg and forearm, but really can happen anywhere in the body where there is compartments, and there is compartments everywhere. Okay, and it can lead to paralysis. This is the extreme that can happen: paralysis, amputation, and contracture. Volkmann contracture. Contracture is basically, as you have seen, because of the force exerting on the muscle, on the soft tissue, on the bone, it gets kind of different shape it takes, right? Your hands, for example, in the contracture, there can be various reasons, but compartment syndrome is one of them. It will lead to formation of contracture wherever there is injury, hand or feet or your legs. It will result in that. Causes can be fracture, bruising, crush injury, excessive tight bandage. And treatment would be, if it's because of the cast, we are going to remove the cast, and we are going to do fasciotomy, which is surgery to relieve the pressure. So that is compartment syndrome. Second complication of fractures is a DVT. And you had a full-blown lecture on DVT, so I am not going into the details of what DVT is. But fracture, you just have to remember, fracture puts you more at risk for DVT. Why? Why does fracture put you more at risk for DVT? Immobility. Okay. What else? Damaged blood vessels. There you go. Blood supply, clotting factors. There you go. Right, right. Now you have a basic understanding. That's very good, right? And so anything that's disrupting your blood flow or normal day-to-day life can put you basically at risk for DVT. DVT is such a, high risk for everybody. Like, for example, if I am healthy person and I don't have comorbidities, I go in the hospital 3 straight days, I'm laying down in the bed, I am at risk for DVT. So what are they going to do? What is the basic thing that they do like 3 times a day in the hospital for prevention of DVT? Heparin. There you go, heparin, right? Among other things, is the heparin medication subcutaneous, which has shown great results. And but anyways, this is all that is, and you have good understanding of that. In brain, it will cause stroke. Lungs, it will cause pulmonary embolism, and in coronary arteries, it will cause myocardial infarction. Okay. The third complication that we will discuss about is fat embolism syndrome. So this we will discuss a little bit more in detail. So what happens is that this is a bone here, and in the bone, what is inside the bone? What is one thing that runs inside the bone? Inside the bone, bone marrow. There you go. So in bone marrow, there is obviously, along with other things that are forming our blood cells, and along with other things, there is a fat as well, which is helping in day-to-day activities of the bone marrow. And now when the bone is broken, obviously the bone marrow is exposed outside. So pretty much 90% of the cases, some type of fat will get out of the bone marrow and will start circulating in the blood vessels. But having said that, not all the emboli, fat emboli, which is the little particles, not all the fat emboli will result in fat embolism syndrome. Okay, and so emboli is the particle. Syndrome is the when it starts to show the symptoms, when it's a full-blown disease, you can say that's a syndrome. Okay, and so let's see what we have put here is it may occur in conjunction with closed bone or pelvic fractures. It is released from bone marrow and enters the bloodstream, can go into the dermal or pulmonary or the lung capillaries. Okay, and these are the symptoms. Now even if you did not know the symptoms, right? Say you forgot and there's a question, or you see a patient with that, and so patient had a fracture, and he is haven't had surgery yet, and we are trying to immobilize, or for some reason the immobilization is delayed, right? Now the patient starts to have short of breath, right? That's the beauty of like all the lectures, if you're able to apply it into your clinical practice. If the patient is having shortness of breath, you do vitals, and the oxygen level is low, right? Now you know that there could be a fat emboli that went into the lungs, right? Vessels there, and it is causing the patient to have shortness of breath, which is emergency. Then they have to go for more testing, or some for example, if it's depending on the area where that is, it can be extracted with the balloon angiography. It's in the coronary arteries or something like that. Okay, and neurological, if it's in the brain, it will cause confusion, headache, seizure. Petechial rash. Petechial rash is the red dots rash seen in the eyes, under the arm, and chest. So this is a very typical something that we see in the fat embolism syndrome. The capillaries underneath the eyes, under the arm and chest, that will start to have these little red dots. Okay, And this is because of the trapment of the fat emboli. Racing heart rate, fever, jaundice. Now, fever is kind of unexplained why it happens, but it's a very, very common finding in fat embolism syndrome. Okay. And so if they have fever along with the suspicion of infection, you should also suspect there might be a fat embolism syndrome. And jaundice, if the liver is affected, the jaundice will happen. So this is fat embolism syndrome. And here there is a little mnemonic: fat, bad, frat, frat. Fat is, you'll see fat in the urine and sputum when we send it for the testing. Bad wing lung x-ray. What happens is that these are your lungs, right? These are the lungs. How is it treated? So for that, we can sometimes do the balloon angiography. We can extract the fat emboli, but mainly they have to put them on the medication for the future use. And and the the catheterization is the what I have seen so far. I'm not sure, depending on the area where it is, they might do something different. For example, for the brain, if it goes into the brain, carotid arteries, right? Carotid arteries are the arteries that are supplying the brain. If it goes there, they might need surgery. They will do craniotomy. They will open the vessels. They'll extract it, right? Similarly, for ischemic stroke, patients who have ischemic stroke, which is a blood clot in the carotid arteries. So sometimes what happens is we can give them the blood thinners, which is TPA. We can give them the blood thinners and we can dissolve the clot. But if they are outside the area where the medication can be given, so they are going to have to do craniotomy. So really, treatment for fat embolism syndrome, it will depend on where the fat is trapped, how they are able to extract it, right? They're going to have to go for some type of surgery, right? For example, there is a vessel and there's no way you're going to get it out. They might put a filter there, right? There's some, again, we don't have to go into that detail because it's a lot of different types of surgeries that can happen. For example, in the, just to give, as you're curious, just to give you an example, for example, in the legs, if there is this vessel and there is a fat emboli, sometimes what we do is we place a filter. We place a filter here so that we are not able to get it out, but at least the filter will not let it go to the brain or to the lungs or to the heart. So it will really depend on where it is found, okay? Yeah, and ever need to get in a filter can stay there. Filter can stay there. It does not hurt. It's compatible, as you can imagine, right? And similarly to the rods and the pins and the needles that stay in the body, and it can come out. Sometimes it gets infected, and then we have to remove it, but it can stay in place as well. Okay, so that is the treatment. And the bad wing lung X-ray. So these are your lungs, and when you do the X-ray, if there is a emboli that we are suspecting, are typically like I'm bad with drawing, but imagine this is like the wings of the bat, and that type of opacity, so you will see on the X-ray. That's basically what it's saying: bad wing lung X-ray and the fracture history. So that's a little mnemonic for the fat embolism syndrome. Okay. So the next complication is simple to follow. It's infection. So you already know about it, that patient is at high risk for infection, low immunity, more risk. These are the three organisms that can infect the area. And signs and symptoms, treatment is antibiotic, proper hygiene. It can cause cellulitis, osteomyelitis, gangrene, okay, and severe infection. And it is all nursing to prevent infection at the site of the fracture. It's really our job more than anybody else, right? And so keeping the site area clean and changing the dressing and taking care of the screw, pin, needle, whatever is there exposed. So it's our job, but simple to follow complication. Emergency care of fracture. So that's important as well. As a nurse, so what you will do if you see at roadside patient has fracture. So first of all is that immobilize the area. You all know that we have to immobilize the area so that it does not cause more damage to the soft tissues or to the bone itself, and to start to heal immediately. Okay, immobilize. We can use splints, whatever is available with you, a piece of wood. You can pad it with some cloth or something that you have, and then tie it around the area. Okay, and cervical immobilization is very, very important. And I'm sure a lot of you have seen already the C collars that are placed on patients. And So if there is a fracture of the cervical vertebrae in the neck, right? Why is it important to immobilize the area? What are we worried about? Paralysis. Yeah. What is the structure that can get damaged, that can cause paralysis? Spinal cord, right, right. And I always say, like, the beauty of human body, or how God has created it, is that the spinal cord is such a delicate structure, right? It can get damaged, and there is a hard structure around it. How nice is that, right? There's hard vertebrae around it to protect it, right? To protect it. And so if that gets fractured, there is a chance of injury to the spinal cord. And whenever patient has C-collar, even in now clinical rotation, I'm sure you see the patients, make sure that every shift or during your shift, you open the Velcro, you take it out and you take a look at the skin. I have seen stage 2 pressure ulcer from the cervical collar, right? And sometimes it's just so dirty that the foam needs to be changed, it needs to be cleaned. Having said that, and you have to make sure that when you take out the cervical collar, you have to completely immobilize the patient's head, right? If they're oriented times 4, you can tell them, I'm just gonna clean up and do a little care there, and don't move the head. If they're not able to, you are gonna need a person to help you with that. You do pressure dressing. One thing that you should not, okay, sterile dressing on the open wounds, assess the extremity. You can do ice packs and treatment for shock if needed. Again, you're not going to do it by yourself. You need some people. If you're all by yourself, these are some of the steps that you can really do, okay? And then call 911. And this is the emergency care that you can do. Basically, immobilize, prevent the bleeding, right? Assess the extremities, and then call 911. That's all you're going to do outside. Okay, type of surgeries. I think a lot of students were just curious from the beginning, what do we do for fracture? So this is what we do, okay? External fixation. So in that, what we do is it's a pretty cool thing too, because I worked in ER. I have seen a lot of putting external fixations. So basically, they take a drill, and they put screws. For example, here I can imagine, like, there is a fracture somewhere here, there is a fracture somewhere here, so they put the screw or pins from the bones up and down. They immobilize the bone, and they put a little rod here on the side of it, and they just hold the bone in place. Okay. And so that way we don't have to cut it open. We don't have to do anything. It's just immobilizing. So this is called external fixation using pins and screws, simple phenomena. And the second type of surgery, there's only two types of like surgeries that we can do. Second surgery, you might have heard of it a lot in clinical, and it's ORIF. The full form is open reduction internal fixation. As the name is signifying, open reduction. First you open it, you reduce it, then you internally fixate it. Okay. For example, if I was not gonna go with here, let me clear the annotations here. So if I was not going to go with external fixation here, what I was going to do in ORIF is make a cut here, make a cut, incision, big incision, okay? And then put the bone together, reduce it, open it, reduce it, put the bone together, and then internal fixation, put the pins, rod, screw, whatever is needed, okay? That is ORIF. Any questions on that? Is that clear? What type of two types of surgery? External fixation and ORIF, okay? And what I was gonna say, orthopedic surgery. Orthopedic surgery is very funny. It's open it like a screw, right? Really a screw. Sometimes it sounds weird when we say that, but if there's a screw in the wall, right? We put it with a drill, we take it out with a drill. That's how we remove it, okay? And orthopedic surgeries, I have worked in orthopedic operation room for a month or so. it's very funny actually sometimes to see orthopedic surgeries. It's extensive surgery, long surgery, but they have instruments literally like a saw, a hammer, a drill, rods, pins, and they would ask you like similar in the similar fashion, like Home Depot. I'm not kidding. And I was just so surprised. The surgeon kept on asking the nurse, "Oh, give me the hammer, give me the saw." I don't know, that's the terminology they use there, but it's funny. And whenever they do that as well, they put the hammer, they are drilling it. It's like literally working on a wall, but again, in a sterile field and all that sort of environment. But that's like OR surgeries. Pharmacological therapy, again, very simple to follow, guys. Analgesics give for pain, opioids you can give, NSAIDs you can give, antibiotics, anticoagulant. Nothing too technical there. And non-pharmacological, actually, that's important. Cast, so we put a cast, okay? And cast, I'm sure you have seen it at least in the TV movies or real life. So what they do is there is plaster of Paris, there is a plasticky material, and there is a fiberglass nowadays they are using, that they put a band-aid on the fractured area, and over that a little wet thing they put fiberglass, and they immobilize that area. Okay, your responsibility is a lot in taking care of the cast, because you have to make sure every single shift there is no compartment syndrome, there is no pain, there is no hot spots signifying infection. The CMS, what is CMS? I think I talk in pretty much every lecture about it. CMS, movement sensation is good. This C is something different.
Circulation, movement, and sensation.
There you go. There you go. So every 4 hours, pretty much every 4 hours, if they are in a critical area, maybe every couple hours, every hour on surgical floor, you're going to do every 4 hour check circulation, movement, and sensation. Okay. And so this is cast. And you cannot, you have to let it dry completely, right? Keep it clean. And you can shower with the cast as long as you kind of cover it and don't get it wet too much. Okay, you cover it with proper plastic bag or something like that. And so you have to be careful with that. And slings, so slings again are easy to follow as well, but very important from nursing point of view again, right? This is an arm sling, this is a leg sling. This is again to immobilize the area. I haven't seen leg slings a lot alone. I have seen it with some other devices, but arm sling is very, very common. I'm sure you have seen that too. Now, although it seems very simple, I just want to reinforce the point that so many times, a lot of times actually I've seen slings are not put in properly. I mean, patient is on the side of the bed and the sling is hanging and the arm is hanging, and it's not doing its job what it's supposed to do. In fact, it does more harm in that way. Okay, so your job is, as nurses, whenever patient has a sling or they put the order for a sling, order a sling from the central supply, and then read the instruction. For example, this type of sling, I had never taken care of a patient with this type of sling, right? I have some other companies, some different things. So for this, if I get this particular sling, what I'm going to do is I'm going to read the instruction. You open the package, there is going to be definitely a pamphlet, there's going to be pictures there, so you read it, right? It's just not possible to teach each and every type of sling or devices that are available. So some things you have to figure it out, or ask the senior nurses. That's always option. Traction. So for traction, I'm so sorry. I don't know what happened here. I think my picture got displaced a little bit, but the traction is putting force on the muscle. So here, listen to this carefully, right? Can be a little bit tricky. It's a putting force with the help of some weights or pulley to pull the muscles and the soft tissue, the connective tissue, the bone alignment, to put a little bit pressure there so that it can heal properly. That is a basic phenomena of attraction. So I have written there, sorry, I should fix this actually, I will. Use of weight rope pulleys to apply force to the fractured bone to maintain proper alignment. Alignment should have been there, okay? And there is two types of traction, skin traction and a skeleton traction. So skin traction, as you can imagine, it is not any not creating any opening in the skin. Okay, it's just putting a little bandage, and you can see here they put a little ace band-aid, not a little, actually it needs a lot of wrapping around, and then they put a pulley over it, and then they hang it with the help of weight. And weight, usually we use bags, actually bags of water. Those are specially designed for a 20-pound weight, a 10-pound weight, depending on the patient. And this needs all physics actually to calculate how much force is needed. We don't have to get into that, obviously, but we will calculate the force by the area, by the height, by the width, and that way we are going to come up with a good weight. But normally it's about 10 pounds actually that we use for this type of traction. So this is a skin traction. In a skeleton traction, what they do is this is a skin traction. Okay, they put a little sling, and they put a pulley here, and they put a weight here. But here, just to keep it immobilized, probably I'm thinking here it's going to be a humerus fracture. Okay, here there's a fracture here. They put a needle here, they put a little pin here, and created an opening here, and then they put a weight here as well. Okay, but you just have to remember that skeletal traction, they put a pin, wire, screws, and that way they hang the weight. Okay, so this is called a traction. Now you got the idea. They can go for surgery, external fixation, internal fixation. They can go for the cast, sling, or traction. These are some of the really treatments for the fracture. Now, these things are directly from your book, all the pictures that I took. These are different types of tractions that can be applied to a patient. Okay, so let's see a little bit about these, and there's a good information in the book as well. 90-90 traction. What happens is there is fracture in the femur, and so we hang the leg like that. Okay, this is the femur, and this is the tibia and fibula, and this is your feet. Okay, and there is a good picture in the book and online as well, probably, I'm sure you can find some. And but this is how it is. And what happens is then we create a screw here, and we put a pulley, and we hang a weight here, so that you have some basic idea of how tractions are made. Okay, and this is a water or weight here, and but this is a 90-90 traction. It can be on one leg, it can be on both the legs as well, depending on the fracture, where the fracture is. Buck's traction is relatively very simple, as we talked in the last slide. So there is a leg, and it's a skin traction. We wrap the ace bandage around the leg. This is the leg. We wrap that. This is the foot, and we wrap the bandage around the leg, and then we put a little device here, and we hang the weight here at the side of the bed, similarly like here. It's a small picture, that's why I drew there, and but it's basically the skin. How can they go to the bathroom? They are going to have to use the bedpan for the time being, absolutely. And so the whole point is to immobilize the area. Okay, and our job as nurses for these tractions is pretty much the same. Monitor the weight. Okay, monitor the complications that can happen: infection, compartment syndrome, DVT, because these are going to be very easy to develop, all of these for the exam. So these 5 types of tractions are in your book, and yes, you're gonna read about these tractions. Okay, and of course these are important. And yeah, Russell traction. Russell traction, instead of a straight leg, it's gonna be pretty much at 30-degree. It's gonna be at pretty much 30-degree. That's the only difference. Okay, depending on the type of fracture and the person. And Bryant traction, as you can see, is that completely the legs are at 90 degrees. Okay, and this is a little poor baby, I know, and it's at 90-degree, and then there is a here. You can see actually what I was talking about. about. This is the bag of water. This is not the weight, it's the bag of water, which is acting as weight, okay? And this is the halo traction here. And halo traction, basically, it's to keep the curvature of the spine straight. That's what's the purpose is for. The kyphosis, scoliosis, the bending of the spine. So it's not really, I might think that it's for the skull fracture or something, but nah, it's really, there is a sheepskin that they use. Sheepskin is soft, and there is a little vest that they have, and they put this halo traction, and there is screws though. They put the screws in the skull. And as much as I just want to mention, actually, as I have worked in orthopedics, I have seen a lot of like halo tractions and other type of tractions. As much as we think that it's going to be, super uncomfortable, I mean, it's screws, for some reason, these are not that uncomfortable. I just want to say that, because of pictures can be a little intimidating. And kids especially, they can have headache or so. Even adults, like for a day or so, we give them NSAIDs, we give them opioids and keep them comfortable, but by the next day they are fine. They are doing their general activities, they are walking around, they actually feel much better, because before that they have a lot of back pain because of scoliosis, kyphosis, and now they have this thing that's keeping their back straight. They actually feel better for the body image, for the pain wise. So as much as we think it's like, bad, it's really helping them, and they are okay. Oh, you saw. So Eileen is sharing that she did saw, but the patient was totally fine. Thank you for sharing. That's what I meant. And, usually patients do pretty good with that. Now, because of all the less invasive technology, halo traction, lower leg of someone had a bone disorder. Okay, it stood up and walked. Yeah, and thanks for sharing. So she saw a halo traction, but I was not aware of that. That it can be put around the leg as well. But the whole point is that these are pretty comfortable, and these are the 5 types of traction, as Ryan was mentioning. So you should have a basic idea of how these are put, which areas these are put, right? And so you should have basic idea of that, not too much detail. And then your role to prevent infection, complications. That's the main thing. RICE therapy is pretty simple to follow. That for every fracture, you are going to recommend rest, ice, compression, elevation. Now, these all are fine. How about ice? There is so much confusion about, should you use ice? Should you use heat? What are your thoughts about it? Why should you use ice? Reduces swelling. Yeah. Why should you use heat? Sometimes we say for swelling as well. Promote circulation. Okay. And so what happens is, for first 24 to 48 hours we recommend ice. Why? Swelling or increased blood flow. Yeah, thank you. Increased blood flow to the area is fine, right? With heat we are trying to increase the blood flow so that good oxygen nutrients go there. But if first 24 to 48 hours of the, especially in the fracture, we anticipate it's going to be a crazy amount of swelling there because of the fracture, right? The inflammation, the everything is going there. So we don't want the swelling to go out of control to the point where it's causing compartment syndrome, right? We don't want too much pressure. That's going to impede the healing, actually. So that's why first 24 to 48 hours we say put like ice, and again prevent any frost biting, and prevent like for 20 to 30 minutes you can put there, not directly on the skin. Have a layer of cloth or something. That's your responsibility, okay? Have a cloth of layer of cloth. And then after that, after first 24 to 48 hours, we can use heat, move towards heat. Lifespan considerations are simple to follow for infants. Any crying area, they are now move, like crying when touching the area, deformity, swelling, signs of infection. Okay, collarbone is a big risk factor for fracture in infants because of the birth injury. You all are working in OB, you can imagine how that goes, and the collarbone can get fractured. And risk are C-section, breech, and low birth weight can cause put them more at risk for fractures. Toddlers and children, so that's important. Nurse maid elbow or radial head subluxation. Subluxation, I know it's a big word. It's really a partial dislocation. You can remember it that way. For example, the knee joint, knee joint. If it is completely out, that is called a dislocation. If it's a little bit displaced, partially displaced, that is called a subluxation. That's how you can really remember it. Okay. And so, but what is nurses made elbow is that we have tendency as parents to hold the kids from their arm, and what happens is their radiocapitellar joint, a joint between humerus. This is humerus, this is elbow, and this is the arm of the child. Okay, and this is the hand. This here is the radiocapitellar joint, and this often subluxate. So this is called a nurse's made elbow. So we have to educate them not to swing and not to hold by the arms. Okay, and long bone fractures are seen. And this is what I was saying. Although all type of fracture in children, you should always, it's a red flag for you. Is there a child abuse going on? Right? Again, that's your responsibility, right? To see that. But spiral fractures are a big, again, a red flag, or you should inquire a little bit more. That's pretty much that is. And then we have nursing assessment. Okay, this is important, very, very important. And 5 Ps. I know you have heard about CMS, but this is another neurovascular assessment that I want to make sure that you check for every patient, even when they don't have fracture, because now you're in learning phase. In clinical, get into the habit of complete head to toe assessment, including CMS, your neuro checks, focus neuro, neurovascular, everything. So these 5 Ps you're going to check in the patient, especially with the fracture. And here I have written that pain, pulse, pallor, paresthesia, numbness, and tingling, and paralysis. Okay, and these are the kind of questions to guide you how to do that, and these are self-explanatory. So basically, a very good nursing assessment is needed in case of fractures or post-surgical, pre-surgical. Okay, and these are the nursing interventions for you. And it's given in your book, easy to follow, easy to read. Promote mobility. We can't just be, having unless there is a contraindication. We should help them with ambulation using passive active exercises. Collaborate really with the physical therapy, because we are not going to know. We are not experts in that, and I don't expect that from you, that you're going to know that at top of your head. So collaborate with the physical therapist. How are we going to do the exercises? Can you guide me a little bit on the passive exercises? Then you follow up. Okay, reposition them. Pain management, you are good with that, right? You can give opioids, you can give non-opioids, you can give NSAIDs, you can put patients on PCA pumps if needed, patient control, and not very commonly seen though. Post-surgically, we see that a lot. But these are some of the things: non-pharmacological, diversion therapy, these things. And then is prevent infection. That's one of the complications. So that's very, very important. All nursing, guys, I'm saying, right? All nursing, that if there is external fixation, so there is going to be rods, there is going to be screws, right? Now, if we don't take good care of that, right, what's going to happen? Infection. The bone might heal, the infection might not after that. That's a big, like, hospital stay, and the expenses and the suffering that patient has to go through. So we have to make sure, and these all are self by this time, all these interventions. So I'm not going to go into detail. Okay, monitor WBC, antibiotics, all that. Monitor neurovascular check. So we talked about it. Perform the 5 Ps, perform CMS, do a good assessment on your part to see any complication happening. So that was all about fracture. That's all you need to know about fracture. Now, a little bit about the hip fracture. You might have some knowledge about it already, but the types of hip fracture. Firstly, this is a normal hip joint. Okay, normal hip joint. So this is a femur. This whole thing is a femur. This is the head of the femur right here. This is the neck of the femur, and this is the shaft of the femur. Okay, these are the 3 parts of femur. So the first type of fracture that can happen is intracapsular fracture. Intracapsular fracture means at the neck of the hip joint, head or neck of the femur. That's where it's happening. Okay, the head is inside, as you can imagine. Now this is your pelvic part of pelvis bone, right, where the acetabulum, the round thingy, the head is going inside. But intracapsular is the neck of the femur. Extracapsular is is in the diaphysis, we say, in the shaft of the femur. That's how you can remember it. You don't need to remember this really for the, but this is just for a basic information that these are the two types of hip fracture that can happen. But really, you just need to know the broadly that hip fractures are any break in the femur bone anywhere, especially the neck or the beginning of the shaft. These are important. Risk factors: old age, osteoporosis, chronic conditions, medications. Some of the medications can weaken bones as well. For example, phenytoin, carbamazepine, like some of the medications, steroids. There you go. Yeah, that's steroids. So these medications can weaken the bones, okay, and that will put you at more risk. Nutritional problem: vitamin D, phosphorus, calcium. These are the main three minerals that make bone. Physical activity: alcohol, tobacco, menopause, and white women are more at risk just from evidence than Black and Asian. And so these are some of the risk factors. Some are modifiable, some are non-modifiable, okay? And type of surgeries of hip fracture. Again, not too much detail here, but the basic understanding is that this is the prosthesis, guys, right? It is made of titanium or stainless steel or something like that's compatible with the body, right? That's durable. And so this is the prosthesis. So this is the acetabular component, which goes into the pelvic bone, and this is the down part of it, right? This is the femur head, and this is the shaft or the stem of the femur. So this is a complete hip prosthesis, okay? Complete hip prosthesis. Now the types of surgeries that we can do is, the first is we do not replace the joint. There is just a minor, fracture, hairline fracture or something. What we do is we do ORIF. Again, you're making connections. See, ORIF. What we did is we did open reduction. We opened it. We reduced the bone. Reduction means put in alignment. That's all reduction is. You'll hear the term reduction. So we reduce the bone and we internally fixate it. We put the pins. We put the pins here, okay? We put the pins. This is ORIF. Then we can do partial hip replacement. What that is, we don't put this. It's as simple as that. Do not put this. Just put this lower part. This is partial hip replacement. Complete hip replacement or total hip replacement is this. You put both of these, right? You put this, you put this. So three types of surgery. These both are ORIF, open reduction internal fixation. And these is a partial, this is complete hip replacement. As simple as that. And post-operative, now for you as nurses, same type of interventions are going to be there as for fracture. For your assessments, for your pain management, for early ambulation, prevention of compartment syndrome, prevention of infection, right? Everything is same. The post-operative care for hip surgery. The one extra thing that I put there is post-operative positioning, which is very, very important, right? Crucial. The whole surgery will fail if we don't follow this simple thing. There is a hip abduction pillow. It looks like that. There is a little abductor pillow, and then there is a Velcro over it, okay? So we always have to maintain the knee, at least for a week, couple weeks, in the abduction position. At home, we tell them to use a pillow, like this picture. Use a pillow for abduction, okay? But in hospital, now that we have technology, we have this thing, okay? So always maintain in the abduction mode, because if we don't, it will internally rotate and the prosthesis will come out of its location, out of the pelvic, the little head, okay? And so this is very, very important on your part, along with the other things that you will do. And so that was all about fractures and hip fractures, and we'll take a break. So there's a little quote that I want to read is, let us always be open to acknowledge, respect, and learn from great leaders in any field or discipline. This is specifically for nursing, because this is by Madeline Leninger, who is the founder of Transcultural Nursing. For indeed, great progress is largely contingent upon thoughtful reflection, critique, and creative use of worthwhile ideas, right? And so we should always be open to take up other suggestions, right? Creativity, thinking outside the box. So, for example, it shouldn't be just a dry topic for you like fracture and hip fracture. I'm just reading it, remembering the risk factors and the sign and symptom. No, when you are in the hospital, you're really not going to treat just one bone fracture. You're going to treat the whole body, whole human, which has psychological and physical and mental and family and all that, right? So you have to be like thinking outside the box because femur fracture is going to look different for different people, totally different, right? Okay, and having said that, you had any questions, guys, on this fracture? And I know I do a lot of talking. How do you distinguish if DVT develops into PE or if it is a FES? That's a great question, Samantha. So for us, for nursing part, right, as we are on the floor, so any pretty much the symptoms are going to be same. That's one thing, right? Fever can be a little different. Is seen with a lot of fat embolism syndrome, and not in the other way around. Jaundice is same. But if we see the symptoms, for us, it's really like the pulse oximetry, respiratory rate, and shortness of breath, and all that is happening, right? Neurologically, they're not good, sometimes. And so what we can do is we will send them, and for the, wait a minute, develop into, what was the question? I lost my train of thoughts. Well, how do you distinguish if DVT? Yeah, for us, we cannot. The treatment might be different, okay? Because for PE, they might put them on heparin. As you can imagine, for fat embolism, there is not going to be any heparin. They might have to extract it, might have to put a filter, might have to do some different intervention. But that's a great question. For your part, maybe the rash, yes, that's a great point as well, Karina. And so the typical rash that happens because of the capillaries in the eyes and chest and the neck area, that can be a little distinguishing factor as well. But immediately, actually, when there is an embolism, all we will see is shortness of breath, change in vital signs, immediately going to call for help, then they will manage the treatment. Sounds good? And any other question? You're welcome. All right, guys. So we will take a break. Uh, thank you. We will take a break until 10:45. Then we will back. We will be back. Okay, for doing the rest of it. Thank you. All right, guys. So let's begin our second part of the discussion, osteoarthritis and rheumatoid arthritis. And I might need extra 5-10 minutes, I think, with this topic, and we'll try to finish it on time, though. And these two, although sound similar, are very different types of disorders, and we'll learn about it. First, it's a rheumatoid arthritis. So sorry, I should have mentioned that. Please write it down on your sheet. This is a rheumatoid arthritis first, but at the second part, I have written that it's osteoarthritis, so that's a distinguishing thing. So rheumatoid arthritis. So pathophysiology is the simple thing that you have to remember for remembering pathophysiology is that rheumatoid arthritis is autoimmune disease. Autoimmune disease. What is an autoimmune disease?
That's the body attacking itself.
There you go. The immunity now is immune system is going crazy, right? It's not distinguishing between your cells and the pathogens. Ideally, it should attack pathogens. And for some strange reason, I'm not sure why, these autoimmune diseases are on the rise, a crazy rise. I see patients all the time on biological treatment having autoimmune diseases. They say stress is a big factor, but for some reason these are on the rise though. And so now in a rheumatoid arthritis, what happens is there is a rheumatoid factors, which are basically the antibodies. Rheumatoid factors start to attack the synovial membrane of the joint, right? Simple thing. So what this is a bone, this is one bone, this is other bone. It's important to actually know the structure before you know the pathophysiology. So this is one bone, this is the second bone. This white thing here is the cartilage. This is the cartilage, okay? A hard structure that's found between the bones, and it's again a connective tissue, helps in smooth gliding of the bone or the joint over each other. Around each joint in the body, pretty much each joint, there is a very tiny synovial membrane. And in the synovial membrane, there is a synovial fluid, right? One layer of cell or two layers of cell, a very thin membrane. It's not very little synovial fluid, but that synovial fluid acts as a lubricant, as you know. It acts as a lubricant. It helps it smooth. So in rheumatoid arthritis, the rheumatoid factors, the antibodies of the body, start to attack what? Synovial membrane. They start to attack the synovial membrane. And as you can imagine, when they start to attack the synovial membrane, there is gonna be all our fighting things, the T cells, neutrophils, they will start to invade this. They will start to destroy this. Inflammation again will happen, right? The whole synovial membrane. There's going to be again the blood vessel, the same phenomena that we studied. The blood vessels will be there. Cytokines are again chemicals that helps in our immune system, that help modulate our immune system, right? In the mobilization of the lymph and our fighting cells. So these attack the chondrocytes. So as the synovial, so one thing to remember is that the antibodies are not directly attacking the joint. They are attacking the synovial membrane, which is inflamed and start to erode the cartilage, intra-articular cartilage. So it start to erode the cartilage right here, okay? So it's clear that the antibodies are destroying the synovial membrane, which in the result will start to erode the bone. It will start to erode the cartilage itself, okay? And there is a formation of pannus. Pannus is basically a hard structure, and here, this is a pannus, as you can see here. Basically a hard structure that is formed by destruction of the vessels, by inflammation, by invading of the T cells and neutrophil. So basically a hard structure that is formed around the cartilage and around the bone is called as pannus. So pannus is formed, and this is how it gets destroyed. This is the basic phenomena of RA. And now the risk factors. it's a strong genetic disposition of rheumatoid arthritis, right? Autoimmune diseases have strong genetic disposition and a family history of RA. This is a gene, HLA-DR4, that is seen in a lot of people who have rheumatoid arthritis, okay? And not just rheumatoid arthritis, actually, I want to say this gene is pretty much responsible for autoimmune diseases. A lot of people with autoimmune have this gene allele, okay? And heavy smoking. Smoking is a risk factor for pretty much each and every disease I have seen. More than alcohol, smoking is one thing that puts you at risk for a lot of different disorders. Obesity, physical, emotional trauma, the stress, day-to-day stress puts you more at risk for autoimmune diseases in general. Exposure to pollution, insecticides, occupational exposure, some of the dust in the factories and other things. So these put you more at risk for rheumatoid arthritis. So these are the risk factors. Joint manifestations. So in this, it's a little different than what happens in usual osteoarthritis or other types of arthritis. The the joints will become boggy, spongy, sponge-like feeling. Joints are boggy because of all the inflammation that is happening, because of the destruction of the synovial membrane. It will become boggy rather than hard. Okay. The one thing that you must remember is that rheumatoid arthritis is symmetrical in nature. Some of other types of arthritis you might see in one hand, other hand is fine. Rheumatoid arthritis is symmetrical in nature. If you have it in one hand, the other joint will get affected. One foot, other foot will. One knee, other foot will get affected. Okay, it's a symmetrical and polyarticular. Polyarticular means more than one joint. It's pretty much, I think, more than 4 or more joints is polyarticular. But anyways, but a lot of joints are affected, not just one joint. Okay. The stiffness is a very common symptom of more than pain. Actually, I want to say that body is stiff. Okay, you must remember one important point is that it's gonna be last for more than an hour in the morning. Okay, one distinguishing factor than osteoarthritis is osteoarthritis, the stiffness lasts for less than 30 minutes, and rheumatoid arthritis is more than 1 hour. Okay, swan neck deformity. Swan neck deformity is this when this is the phalanges, and there is a little raised, and then the distal phalange will be kind of crooked. Okay, there's a picture here. There's a nice picture in your book as well. You can watch some like online pictures as well, and to get a better understanding. But this is a distal flange. This is intermediate flange, and then there is a little crooked. This is swan neck deformity. Boutonniere's deformity. It's basically in Boutonniere's. It's in the hand. In the hand, this is how it's going to look like a claw, like a claw. Okay, this is again the positioning of the joint really. Oh, you can see actually on my finger as well. Here, if I have straight, and here it's the distal flange. This is the distal flange. This is intermediate. This is the proximal flange. Okay, and if the distal is kind of crooked, this is swan neck deformity. If it is like a claw, like the whole thing is crooked, this is a boutonniere deformity. Okay, this is if you are pointing. Yeah, do you see my picture? Okay, you don't see in my picture, but anyways, this is how I drew it here. This is the proximal flange, intermediate, and distal flange. Boutonniere's deformity, and then swan neck is that distal, intermediate is okay, and then it's kind of crooked at the end of the finger. This is a finger that I draw. This is a finger, okay? And these are two types of deformity that we see, but basically stiffness lasting for more than an hour, okay? And symmetrical, polyarticular. These are the joint manifestations. In knees, we see visible swelling, we see instability, quadricep atrophy because of the inflammation and that's happening. The quadriceps, the calf muscles, and it will start to atrophy. To kind of like get weakened, and less mass there, less mass in the muscle, right? It will become atrophied. The muscles in the femur, muscles in the calf, because of the inflammation moving from the joint to the nearby muscles as well. Contractures will happen. Knock knee. Knock knee is simple to understand. This is a femur. And here, this is how it's going to look, knock knee, that it is very close to each other. These are the knees, these are the knees, okay, knock knee. And ankle and feet ambulation, again, pain, subluxation will happen. What is subluxation?
Partial dislocation.
Okay, thank you. Yeah, thank you. And partial dislocation. So in ankle and the feet, partial dislocations can happen. Again, having said that, complete dislocation can happen as well, depending on the amount of the erosion of the bone. Okay, hallux valgus is bunion. It's another name for bunion. Bunion. I'm sure you know that, right? And in the ankle. And great toe, this is a foot, and this is the great toe, and the great toe will get displaced to this side, to the inner side, and right here it's going to be a little bone protrusion that is called a bunion. It's also called hallux valgus, right? A lot of people we see in the hospital. Cock up toes is, again, it's a little, you don't have to remember this each and every, like for example, cock up toes, right? It's just to mention that, but you don't have to remember how it looks. It again looks as the claw, like it's going to be a crooked toe, right? And that is cock up toe. The things to remember would be hammerhead toe is a little different, Anna. It's just depending on the shape, actually. All these things can be seen in. The important will be swan neck deformity. Swan neck deformity is the important one. The rest is for your understanding, hammerhead toe as well. There's a lot of different abnormalities that can happen with the shape of the joints, okay? Swan neck, and the other thing that you must remember is that it's a symmetrical in nature, it's polyarticular, the stiffness lasts more than an hour, okay? And it's soft and spongy, like these are the rheumatoid arthritis things. Spine, again, it's the movement will be limited, will be neurological complications and neck pain, okay, in a rheumatoid arthritis. Now, this systemic manifestation, so I want to talk a little bit about that. One of the distinguishing factors of rheumatoid arthritis than osteoarthritis or any other type of arthritis is that it is going to have systemic manifestation, because it is an autoimmune disease. A lot of times we as students or in healthcare field, we would think that rheumatoid arthritis is something that just affects the joints. It does not, right? Because it is autoimmune, it is attacking other parts of the body as well, or eventually it will start to attack other parts of the body as well. So what happens is it's going to affect your eyes. If it affects your eyes, it is going to cause scleritis and episcleritis. That's basically the sclera is damaged or inflamed. Sjogren syndrome. This is a picture from your book, directly I took from your book. Dry eyes and dry mouth. This is a Sjogren syndrome, which is also an autoimmune disease, which causes dry eyes and dry mouth. Vasculitis pericarditis in cardiovascular. It's attacking the heart. The splenomegaly, neutropenia, anemia, as you can imagine, these are the immune responses that's happening. Felty syndrome, okay, this can happen. Integumentary rheumatoid nodules, little nodules are going to be formed all over the body. Respiratory, pleural disease, interstitial pneumonitis, and these are some of the things that we have already discussed. We already discussed musculoskeletal. Okay, so you'll remember that this is a systemic disorder. It's not just with the joints. We have discussed this musculoskeleton, but along with that, there is going to be heart and lungs and Sjogren's disease, and these are going to be involved as well, because it's a systemic disease. Systemic is when it's like circulating through the blood, it's all over the body. Some of the diagnostic tests is you do complete blood count. Complete blood count, there is no, what are we looking at in complete blood count? WBCs. Yeah, there you go. WBCs are the main things, right? So you have good understanding of what complete blood count is. It's a RBC, hemoglobin, WBC, platelets, everything that's found in the blood, okay? And then blood chemistry is your liver function test, renal function test, and your electrolytes. Okay, rheumatoid factors. Rh factor, you might have heard about that. And normal range, you don't have to remember, it's about like 14 to 15. And rheumatoid factors, if present, definitely patient has a rheumatoid arthritis or rheumatic disease, okay? But sometimes this is negative and still people have rheumatic disease. It's not a confirmatory test, but if it is present, then definitely that's a confirmation of rheumatoid arthritis or rheumatic disease. These are the second type of antibiotics, and you should remember this as well, CCP, cyclic citrullinated peptide. These, along with rheumatoid factors, these are second type of antibiotics that are seen in rheumatoid arthritis. ESR, erythrocyte sedimentation rate. This is very important that it is raised. I haven't written the normal level. It's about 22, 15 to 22, 10 to 22, something like that. But you don't need that. You just need to remember that in ESR will be elevated in rheumatoid arthritis. What is other condition? What does it signify? If ESR is high, what does it signify? I'm sure you have heard this in one other lecture. Inflammation. Okay, there you go. Inflammation is the answer. Okay, so what this is this is important concept for your clinical practice as well. So they take a tube, right? They take a very tiny thin tube and they put blood in that and they literally leave it for an hour or so. The time that it takes, not the time actually, the volume of the RBC will start to accumulate at the bottom. The volume of the RBCs is called the ESR, erythrocyte sedimentation rate. Volume of deposition of RBC, I should say. For example, if it is 22 millimeter per hour, okay, that means that this much RBCs are accumulating in that tiny little tube per hour. If there is inflammation, more RBCs are gonna get clumped get accumulated at the bottom, right? More RBC, because inflammation is joining the RBC. Inflammation usually join the RBCs together, so more are going to coagulate at the bottom. So this is basically ESR, important one, okay? ESR. CRP. Again, it's a protein made by liver, but you just have to remember in any type of inflammation, CRP will be elevated as well. Okay, CRP. So rheumatoid CRP is elevated. ESR is elevated. Rheumatic factors can be present. CCP can be present. X-rays, of course, like X-rays we can do for the joints, right? To see if there is any opacity, there is any bone loss, something like that. Okay, surgeries. What can we do? Very simple thing is that first thing, you know that there is a synovial membrane which is inflamed, which is damaged, which is not good. Do synovectomy, right? Synovectomy. What is synovectomy? Excision of the synovial membrane. Makes sense? This is a bad part, remove the bad part, right? And what are your thoughts about if we remove the synovial membrane, and how will the joint function? There is not going to be any lubrication. What do you think? It will cause pain, not well, painful, no movement. Okay. And so what happens is synovial membrane regenerates. There you go. Can you replace it? That's a good thought, right? Critical thinking. Can you replace it? Is there a way that we can put it back? We cannot, but the body regenerates it. Again, having said that, having done that, the patients are at higher chances of rheumatoid factor again attacking that synovial membrane. But what is our preventive measure is that we start them on some medications to keep the immunity down, to keep the rheumatoid factors down. So all in all, the thing is that if we take out the synovial membrane, it will regenerate. So we don't have to worry about it, okay? It will regenerate. And arthrodesis. How long? I am not sure, Eileen, about that question. That's a good question, though. How long it takes? I am assuming that it's going to take some time, definitely a month or so. And depending on the severity of the disease, it might take longer, and the comorbidities and all that. And but for that, they really would have to, I'm assuming, have to go for some testing or something. And I'm not sure they even test actually if it has regenerated or not. But it can. So it will help with the movement, with the day-to-day life. Arthrodesis is a joint fusion. joint fusion. So what you do is there is erosion of the bone, erosion of the cartilage at the joint. So you join them. You join these two so that it does not. So you obviously take the bad part out, or you put them on some medication to keep the immunity down, and then you join these parts, right? Arthrodesis. And what are your thoughts about movement of joint then? Joint fusion. You might have heard of that, or we are especially on surgical floor actually in a clinical area, so we see a lot of these surgeries, joint fusions and replacements and things like that. But what are your thoughts about joint movement? What's going to happen here? Unable to bend, there you go. They're not going to be able to bend. It is what it is, right? It's limiting. The movement is going to be very limited, but that's what's needed. That's what less invasive. The patient was not a candidate for joint replacement because of the comorbidities. They went for arthrodesis. Okay, joint fusion. Arthroplasty, that's just another name of plasty. Plasty is a replacement, right? Pretty much like our repairing it, replacement. And arthrobone, so total joint replacement is called arthroplasty. That's always an option. That's like end option, really. These are three types of surgeries that can be performed for rheumatoid arthritis, okay? And other is non-pharmacological, simple to follow, heat and cold nutrition, orthotic and assistive devices you're gonna give depending on the joint. Plasmapheresis irradiation. I don't wanna go into too much detail of this, but this is basically purifying blood, just to have a basic idea, because at some point you're gonna hear about it. And basically it's a taking plasmapheresis is taking the blood out of your body, filtering the plasma that has bad antibodies, Rh factor, filtering the plasma, putting the blood cells back into your body, and then giving you extra plasma, or giving you good plasma, or giving you IV fluids to create that blood volume. People go for plasma donation, right? It's the same process. They go for plasma donation. Plasma is filtered out, taken out, and in COVID we saw that a lot. And then blood cells are replaced back. Okay, plasmapheresis. Irradiation is with radiation. They kill the antibodies, bad antibodies. That's basically what it is. You don't have to go into the detail, have a basic understanding what these procedures are. Complementary therapies are, I wrote here, none shown to be effective as per your book, and but a little more research is should be done, because I have seen a lot of holistic and complementary therapies being done for rheumatoid arthritis. Various websites are there, and so really something to check out. And a lot of complementary therapies, there is a scarcity of research in those, but acupuncture, hydrotherapy, fish oils and minerals and plant extracts, these are some of the things that can be done for helping juvenile idiopathic arthritis. As the name is suggesting, that as I told you, that it's a genetic disorder. It not a genetic disorder actually, but your family history, genetic predisposition puts you more at risk. So similarly, it's not just seen in the older people like osteoarthritis. It can be seen in little kids as well, teenagers. So between 3 to 6. And puberty around in girls more seen. So joint swelling can happen. Treatment is similar like adults. Discontinuous, sometimes aspirin is taken for the pain and to help just for the comfort. But as we have discussed last semester, that aspirin puts kids more at risk for Reye's syndrome, which is a neurological syndrome. So if there is any symptoms of Reye's syndrome, we should immediately discontinue aspirin in kids. Okay, this is not just for RA, it's for every single thing for which they are taking aspirin, which is really over the counter, but it can cause bad neurological symptoms, confusion, and I don't know, maybe seizures at some point, I'm not sure, but really the confusion and stuff. And then we should discontinue this and immediately call 911. Maybe chronic, so a lot of kids after treatment, they will be in remission for years or lifetime, and they would not have it in the later life. Three types of juvenile arthritis is a polyarticular, systemic, and polyarticular. If less than 4 joints are involved, that's polyarticular. If more than 5 joints in the body are involved, that's a polyarticular arthritis. Systemic is increased risk for absolutely, absolutely. That's a great question. It does increases your risk in the later life because we know that antibodies are there, okay, that are attacking the. Although they are in remission, they might get it later in the life. Absolutely. And systemic is, systemic throughout the body. Okay, these are 3 types of juvenile arthritis. Increase for RA2, absolutely, it does increase your risk for getting RA in the later life. Okay, some people lifetime they're in remission, some people maybe for a year or so, and then it comes back. Okay, and the symptoms of the RA in kids, it's pretty similar to what we see in the adults as well. Fever can happen because of all the inflammation. Rashes can happen because of inflammation. Lymphadenopathy because the lymph nodes are going crazy, making all the antibodies. Splenomegaly, hepatomegaly. Systemic is same as RA. Yes, absolutely. Systemic is same as RA. And splenomegaly and hepatomegaly. Spleen is big, liver is big, right? These 2 things, these are organs that help in our immune response to the body. That's why they get bigger, because they have to now produce more chemicals for the immune response. Spleens, for example, is a main organ in your immune system. And slow growth or uneven growth can happen. Chronic uveitis, uvea is a structure in the eye, and that can also be attacked by the rheumatoid factors, and it can cause chronic uveitis. Uveitis basically is your I think it's your sclera, coronal body, ciliary. This is all from your anatomy. So uvea can get affected, okay, and normal growth. So these are some of the symptoms, guys, that with the juvenile arthritis, it can happen, okay? Pretty similar though. And pregnancy. So pregnancy, they say that in pregnancy, all of the autoimmune diseases, they can flare up, maybe in remission, relapse after delivery, and so they can either flare up, they can be in remission. The reason is unknown, but as you can imagine, it's really the stress on the body, the physical stress on the body. As now there is a baby, you are supporting the baby, there's more oxygen, more nutrients needed, and these things can flare up. Okay, and about the medications in pregnancy, really it's a provider that they have to weigh the risks and benefits, and some of the medications are safe, and we don't have to go into detail, but that's really at the provider discrepancy, right? And your assessment. So first is observation and patient interview. Depending on the symptoms, okay, very easy to follow. You will check the gait, posture, joints, deformity, pain, stiffness, fever, sleep pattern, and other. Quick question, for how long the stiffness will stay in rheumatoid arthritis? 1 hour, more than 1 hour. Okay, that is the basic rule of thumb for the rheumatoid arthritis. So you're going to check that. Physical examination, you will check weight, height, joints, skin, respiratory, and all these deformities that we can. So really, I spend a lot of time on symptoms, on risk factors, so that nursing assessment comes very natural to you. Okay, rather than spending more time here. So now you have a good, clear understanding of what you are going to look for in a patient with rheumatoid arthritis, okay, depending on risk factor and symptoms. Manage pain. Again, you have a very good understanding of opioids, non-opioids, narcotics, and the non-pharmacological therapies, assessing the pain. What is the mnemonic that we use for assessing the pain, guys? OPQRST. Yes, OPQRST. Yeah. And right, that is the mnemonic. And I'm not sure if I have talked about it in the lecture. Maybe it's a little different. So OPQRST, any patient who tells you when you go in there that I have pain. So you are going to check for this mnemonic. I will put that. I don't want to spend a lot of time. This is a lecture of pain, which is really origin. Okay, what is O? What is O for the pain assessment? yeah, right. I have put it. That's origin, right? What is P? Pain. Okay. Um. Okay. No. Okay. What is Q? I have to write it down. What is Q? Q. Quality of pain. Okay. Quality of pain. Provoking factors. Yes. Quality of pain. O P Q R. What is R? Radiation. Yes. S. Severity of pain. T is the timing. Okay, right? So you can write it down if you are taking notes. So any patient says, I have pain, any type of pain, head to toe, okay? And you can't just ask them, what is the level of pain? And then just, start managing the pain or doing your intervention. No. Origin of pain, where is the pain located exactly? What are the some of the things that making it better or worse, right? And what is the quality of pain? Is it sharp, dull, burning, stabbing? How is the pain? Radiation, is it radiating anywhere? Severity, now from 0 to 10, how would you rate it? Timing, when did it start? Okay, it's a full-fledged pain assessment. So that's what you're going to do. Manage fatigue. So these are simple mechanisms of manage fatigue, but very, very important actually, that you have to encourage them to take it easy, know their limits. Although you promote exercises, and but depending on the collaborate with the physical therapy to really make a good plan for their activity. Okay, and ineffective role performance and positive body image. So this is the main thing, that with the autoimmune diseases in general, with this diagnosis comes a lot of stress, a lot of changes in your life that's going to happen over next few years, or for the lifetime. You have to go through the treatment, so you have to make sure that you touch base with the psychological aspect of this disease as well. Okay, involve their family, promote mobility, we already talked about it. And okay, this was rheumatoid arthritis, right? Totally different autoimmune disease and immunity and all that. Now, osteoarthritis, though it's so similar, it's a really a joint problem. It's a really joint problem, much simpler than rheumatoid arthritis. I don't want to say that again. Symptoms can be really bad as well, but this is like weak bone, and it's causing osteoarthritis. Okay, so healthy joint, cartilage is good. Cartilage, now you have a good understanding. What is the cartilage? What is cartilage? Connective tissue. There you go. So between two bones, there is a white color connective tissue that's hard, that helps with the smooth gliding over each other. On the side, there is a synovial membrane, right? And yeah, cushioning. There you go. Healthy joints. And healthy joints are going to have a good cartilage. As the person ages, then it's going to start to rub against each other. There is less lubrication. Cartilage is lost. And now the bone is going to start to damage. That's it. That's osteoarthritis, as simple as that to understand, at least. But there's going to be pain and swelling, inflammation, and no longer smoothly glide over each other, as you can imagine. Mostly it's seen with age, over 50 or so, depending on the person. Etiology is causes why it happens. Idiopathic osteoarthritis, no known cause. It's because of continuous mechanical molecular forces and factors. And it can be localized or generalized. Localized is 2 joints, 1 or 2, and generalized is more than 3 joints are affected, right? Joints, knee joint, hip joint, or phalanges, right? And in the elbows, wherever there are joints. Secondary osteoarthritis is because of some other things going on in the body. For example, bone cancer, I said. Osteoporosis, I said, right? Osteogenesis imperfecta that we talked about, the brittle bone disease. So it's because of something you are getting osteoarthritis. Okay, that's a secondary osteoarthritis. Risk factors are very simple to follow. Old age and above 40, and 80% are above 45. 60% of people are women, so women are at more risk, and these are the locations where it can happen. Obesity and malformed joint, again, having. So some other diseases that are putting you more at risk are diabetes, hypothyroidism, gout, Gout, you haven't studied it yet. I think you will at some point. But gout is basically a type of arthritis, but it is because of uric acid. There you go. Thank you for sharing. So more elevated level of uric acid in the blood will cause you to have gout. But it's arthritis. Paget's disease. Paget's disease is probably you will not study about it at some yeah, because it's not that common, but Paget's disease is that your bone loss and bone formation is happening very quickly. Reformation, bone is getting lost because of the osteoporosis or something, and because of weakness or degeneration, and but it is getting formed very quickly, and there is just a malunion and malfunctioning at the bone. But that's like Paget's disease. We don't have to go into details of that. That's a bone disease as well, putting you more at risk for osteoarthritis. Clinical manifestation, simple to follow. You will have joint pain, stiffness. Okay, this is what I want to stress again, right? That the separating factor is a stiffness in the morning is more than an hour in rheumatoid arthritis, less in osteoarthritis, it's less than 30 minutes. You can remember it that way. Osteoarthritis, pain takes the lead. Rheumatoid arthritis, stiffness takes the lead. There is more pain in osteo than rheumatoid generally. There is more stiffness in rheumatoid than osteoarthritis. Joints are going to be tender to touch, swelling, crepitus, grating of the bone, bone spurs. I put it there. I'm not even sure what that is. I'm so sorry. And probably grading. I'm really not sure. Bone spurs, but you can leave it as you can imagine. I'm not sure. I'll check that. Decreased range of motion. Okay, that's simple to follow. Other things. So then diagnostic test, as you can imagine, now there's not going to be any RH factor, no ESR, no CRP, no nothing. So only do your X-ray, your MRI, ultrasound, joint fluid analysis for the inflammation and everything, and blood test to rule out other causes if you have bone cancer and other things going on, diabetes, hypothyroidism, and but all the general imaging testing, I want to say we do. And surgery again are pretty similar. The next slide, actually, it's similar surgeries, but here what we can do is we can do arthroscopy. Even if you don't know the surgery or you forget, right? And you can just dissect the word. Arthro is bone, scopy is that you put a scope in there. This is arthroscopy. This is the camera. This is the camera right here. Arthroscope, okay? They make a little hole, they put the camera in there, and they do debridement. The bad tissue, they debride it, right? The cartilage, they debride it. Joint irrigation, they can irrigate the joint. They can, with the antibiotics if needed, with the simple fluid if needed, so they can irrigate the joint. Second is joint irrigation. Joint resurfacing, what that is this is bone grafting, I think. Joint resurfacing. A small amount of bone is removed, metal replacement, it fitted over end of the bone, total joint replacement. So what happens is, this is your bone, right? And this is the, say, second bone, and osteoarthritis has happened. What they are gonna do is, they are going to take the surface that is bad, they are going to take it out, right? And they're going to put a piece of metal there. They're going to put a piece of metal, okay? And to replace that. Osteotomy, as you can imagine, this is cutting of the bone. Osteotomy. So they, what they're going to do is a simple phenomena. They are going to cut the bone, as you can imagine. They're going to cut the bone. They are going to take a graft from some other part of your body, for example, hip bone. So hip bone, or this is the picture actually that they showed. This is taking a bone graft. This is a good bone. They take a little piece of bone from there, because this will regenerate, right? This is not going to get affected because this is a very healthy bone. You take a graft and you put it here. Okay, so this is a bone grafting. So some of the things you can do: arthroscopy, joint irrigation, resurfacing, putting a metal there, taking the bone out, osteotomy, cutting the bone, putting a graft there, okay? And simple things. Now, these two, I have already talked in detail about joint fusion and arthroplasty, right? Arthroplasty is a replacement. What is two types of replacements can be done? joint. For example, for the hip joint, right? What is total or partial? There you go. Thank you. Yeah, total or partial, right? And arthroplasty is the joint replacement, and joint fusion is the joining of the joints. And artificial usually lasts for 15-20 years, but now it's like really good procedure, less invasive, and they do pretty good. After that, recovery time is 6 weeks to 6 months. Okay, these complications can happen that we talked about already. Non-pharmacological treatment, again, the same, heat and cold, assistive technology. Weight reduction is a big thing actually in osteoarthritis, and we tell them to reduce weight. That can help with the forces happening at the joint, and it can help with the overall healing, coping techniques, exercises. And complementary therapies, again, these are some of the therapies, have mixed results, but can be done. Stem cell therapy undergoing investigation. This is a relatively newer technique, that there is stem cells, that the stem cells, sometimes for kids, babies, we do the stem cell restoration. So these are the cells that can modify themselves to make any other cells in the body. So that is under investigation, if that can be used for osteoarthritis and even rheumatoid arthritis. Lifespan consideration, I have already talked about in length, in detail, about juvenile osteoarthritis and in pregnant women. And again, they are at increased chances of pain because of the shifting of the weight, and some medications may be dangerous. And again, at provider's discretion, we don't have to go into detail of which are safe, which are not. But anyways, it's not many medication that you can take for osteoarthritis. So they really have to consult with the provider. And yeah, so here, sometimes the NSAIDs are not that safe for older adults because of the chances of NSAIDs, especially in older adults, it can cause what side effects? Bleeding. There you go. GI bleed, especially, right? And because it erodes the mucosa, peptic ulcer, esophageal ulcers. So sometimes we think narcotics are bad, but sometimes the risks are more with NSAIDs. Okay, so we really have to think about it. And again, these observation and physical assessment, I have talked about pretty much everything except these Haberden and Bouchard nodules. And these are something that happens. These are the little nodules at that. You don't have to go into detail, but just remember that when you see osteoarthritis, say, for example, I take the example of hand, you'll see these nodules happen at the joint areas. Those are two types of Haberden and Bouchard nodules, okay? So we check for that during our physical assessment, along with everything else that we have said that. Okay, that's a good question. If I have written that, observe for signs of pain and shortness of breath. So again, the main explanation for rheumatoid arthritis would be better, right? Because that can systemically affect you. This should not be a big factor, although I have put there, probably it was in book, it should not be a big factor. Having said that, it probably is thinking because of the bone erosion that still the inflammation will be there. If it in any way is affecting your lungs or something, lungs or the breathing, but shouldn't be. That's a great question, actually. It shouldn't be a big factor. Yeah, it shouldn't be a big factor there, okay? And but in general, I think they just put everything in the assessment, and but not a big factor. That's a good point. Thank you. And interventions. So for interventions in osteoarthritis, you are going to promote comfort, you're going to collaborate with therapy, and a balanced nutrition. Okay, weight loss program, nutritionist, dietitian. So you're going to collaborate. So it's with rheumatoid and osteoarthritis, it's a multidisciplinary approach that we really need. Okay, and we have to involve everybody, because we can't be experts in everything. I cannot tell you how much force they need to put on a joint that has a severe or not severe form, right? But I can collaborate with the physical therapist for that. And then, okay, this is a little picture. The last one is so that you can remember a little differences. I have already talked about it though. This is an inflamed synovium. This is a cartilage loss, okay? Osteoarthritis and rheumatoid arthritis. Morning stiffness more than 30 minutes. It's less than 30 minutes. It's really 1 hour, actually. You can change it to 1 hour, but little distinguishing factor I think they have put there is morning stiffness less than and more than, okay? And in this, we see this Haberden nodule, Bouchard nodule. This is asymmetric. This is the main thing. It's asymmetric. Rheumatoid is symmetric, okay? Extra articular involvement, more than the joints, more than the joints. This is a degenerative disease of joints only, okay? So these are some of the, and I hope you have clear understanding of what osteo and rheumatoid arthritis is, okay? And after that, I just have like a very quick, I need 10 more minutes, guys. I'm sorry, I know I'm over the limit, and to discuss pharmacology. That's gonna be quick. Nightingale believed it's critical for the nurse to be knowledgeable about factors influencing health and illness and to be totally committed to her patients. For Nightingale, nursing is a calling, not a vocation. Joyce, she was a nurse too. And right, so not just passing out medications and not just like going there and following provider's order. No, 200 years ago, she said you have to be knowledgeable about the illnesses, about the health of the patient to take good care of the patient. Okay, so before going to the pharmacology, do you have any questions on osteo and rheumatoid?
There's a ton of content, in your slides today. It was very thorough, but there's a lot there. Is there any way you can give us the big picture takeaways? Is it really just at the end of it all just dividing osteoarthritis versus rheumatoid in terms of knowing the differences? Is that the key?
So all the content that I have put in the PowerPoint, I have tried to not really go outside the information that's presented in the book. And even the book information, I have tried my best to limit it to what you need to know. And so the big takeaway from rheumatoid and osteo, that would be that, and you made a good point that it is a big thing to distinguish between rheumatoid and osteo, right? Having said that, specifically for rheumatoid arthritis, what are the risk factors? What are some of the things that patient are going to present to me, right? And what are some of the assessments I'm going to do? What are the systemic things that patient can present with, right? And which is more than really a distinguishing factor from osteoarthritis. And so you still should know, yeah, and know the ADPI as well from nursing point of view. And I thought I put like all the important things in the PowerPoint. And yeah, so you really, I think if you read the PowerPoint and if you follow the discussion that we had here, that should be more than sufficient for you. Is that lot? Okay. Thank you. Okay, and but 2 hours lecture and these PowerPoints are, I think it's a good content. It's not too much, it's not too little. This is sufficient, I think, that you really need to know. So if you just follow my PowerPoints and you follow through the discussion, I'm sure you're all actively participating, which I'm very happy about. And so that should be sufficient for you for the clinical practice, for the exams, for everything, okay? And again, having said that, you have any questions, please arrange a Zoom meeting with me. I'm always available via email for meetings, and I can guide you a little bit more if you need individual help, okay? And okay, so let's go into pharmacology. And so I know there was a lot of confusion about pharmacology, about drugs, and how to study about it. So I have tried to now put everything in the PowerPoint. It's like literally 10 or 9 slides that I have there. And so here in gout, this you can cross. This is a picture from your book that I did not crop. And so this we don't need. Osteoarthritis, and the bottom it says the treatment. This is a little picture to guide you, and this is for rheumatoid, but there is a bigger picture so that you don't have to, it's so tiny you can't read it, but there's a bigger thing here. So for osteoarthritis, as you can imagine, I want to make it very clear so that you're not confused here, that osteoarthritis is all you can take is really for inflammation, you can take NSAIDs. For inflammation, for the little inflammation that can happen, there is not much. You can take for pain Tylenol, right? For pain, you can take NSAIDs. You can take topical medication. There is one diclofenac. You don't have to know this name, trade name. You can cross it out, okay? Diclofenac. This is also a pain medication, which is not a narcotic. And capsaicin cream. Capsaicin cream is like Bengay. You can take it over the counter, but you might hear it in clinical practice as well. So topical medication. Over the medication, sodium hyaluronate. Have you heard about hyaluronic acid? It's like a lot in the beauty products, in the beauty stores, you'll see hyaluronic acid. It's a moisturizer, deep moisturizer. Basically, this is a chemical that is found in synovial fluid. Okay, in synovial, that helps with the lubrication. So sometimes the doctors, they put this injection in the joint, hyalogen or sodium hyaluronate. It's a chemical. So very simple, right? Literally one slide, no detail. Osteoarthritis is fine. You take Tylenol, you take NSAIDs, you take pain medication, topical, the injections. That's all we need to know, okay? And now rheumatoid arthritis. The first couple things are very easy. The NSAIDs, you can imagine there's a lot of inflammation. Rheumatoid, inflammation, go hand in hand, inflammation, right? And NSAIDs and corticosteroids. As you all know, this is given for inflammation. The first two are very self-explanatory. Now, I want to talk a little bit about disease-modifying anti-rheumatic drugs. It's in your book around page, I have put in the reading, 745 or something. That's a page, one page there is, if you need a little more reference, but I have tried to put this in the PowerPoint as well. So these things are immunosuppressants. That's how you can remember that. So these drugs are immunosuppressant that suppress your immunity, or it modifies your immunity in a way that it's not acting against the body. Okay, it's not against the body. So here I have put that. It's immunosuppressive, it's immunomodulatory, okay? It is used for rheumatoid arthritis, and these are some of the other autoimmune diseases, okay? So psoriatic arthritis, spondylitis, SLE, Sjogren's disease, systemic sclerosis. These are some of the other autoimmune disease for which DMARDs can be used as well. Disease modifying anti-rheumatic drugs. Okay, DMARDs. Don't get intimidated by the name. It's simply they modify the immune system. Right? Modify the immune system. And this is important as well because there's a lot of talk, a lot of clinically we see patients on these drugs now. Okay, there is three types of disease modifying anti-rheumatic drugs. The first is synthetic drugs, non-biological, okay? There is three names that I have put there. Hydroxychloroquine. Does anybody know which is the other disease for which people take it? Chloroquine, hydroxychloroquine. Might have.
COVID? Were they giving that for COVID?
Yeah, there you go. There was a lot of talk about it. I don't want to go into detail, but chloroquine, it's for malaria, right? For malaria, they were giving it. And then during COVID, they said it might be effective for patients, chloroquine, okay? And it's also called Plaquenil. But chloroquine, methotrexate, which is really given for cancer to suppress the immunity or to attack on the cancerous cells, sulfasalazine. These are three drugs that are synthetic, and yeah, absolutely for lupus as well. Thank you for sharing, because it is an autoimmune disease. Lupus is an autoimmune disease. So we give methotrexate, sulfasalazine, hydroxychloroquine, synthetic drugs that will suppress the immunity. That's all you need to remember. Not too much detail at this point, okay? At some point you will. And the second is that these two things, biological. Now, this was synthetic, but then there is a lot of talk about biological. What that is they extract these medications from your cell proteins, okay? And these are the three. adalimumab, infliximab, and golimumab. Anything ends with mab, actually. You don't have to remember much, okay? I'm making it simple for you. Anything ending with mab, just remember it is a biological. You don't have to be able to differentiate between TNF and non-TNF, okay? It was given in the book, I put it there. But anything ended with mab is gonna be your biological antagonist, which is extracted from your cell protein, but it helps with modifying the immunity, okay? The only one drug that you have to study is Humira. That is your prototype drug that is given in your book as well, okay? So little background on that is it's the same things that we have already talked about, really, when you read through it, that it is the monoclonal antibody approved by FDA. This was the first drug. This is a subcutaneous shot that patients give. These are used for these autoimmune diseases, okay? And it is comes with a pen-like injection, which is a subcutaneous shot, okay? Only one drug that you have to do for now. Administration alert is that you always want to talk to your provider. You have to learn injecting. You have to collaborate with the nurses, dispose in the sharp container, notify if you're pregnant, okay? These are the onset of action. And adverse effects. So adverse effect, I want to talk a little bit about that because this is very important. Humira, it will cause at the site of injection, it will cause pain, and it can cause respiratory infection, creatine phosphate, headache, and rash. These are some of the adverse effects that can happen. But at the injection site, this pain, swelling, hematoma, that is
What?
very common.
We might be out of apples.
And okay, so black box warning is, this is the warning, guys, that they give with all the biomarkers, that it can cause leukemia, it can cause cancer, it can cause lymphoma. There's a lot of side effects that can happen, and contraindication is you already have malignancy infection, it is contraindicated. And for the drug reaction, I want to mention that only one biological marker you can be on, okay? You cannot be on two biological markers. For example, Humira and Remicade. No, you can be only one biological marker, okay? That's what pretty much it says here on this slide. And the herbal food, it's just for your knowledge. All right, so it was only one drug. So all hurry or bustle is particularly painful to sick. Always sit down when a sick person is talking business to you. Show no signs of hurry. Give complete attention, full consideration if your advice is wanted. Always sit in patient's view so that when you speak to him, he has not painfully to turn his head around in order to look at you. Sometimes I understand you're busy, but especially during clinical rotation, you should be able to just sit down with them. I'm so sorry, I'm over the time, 10 minutes. I'll open the session for taking questions, guys. Any questions for me from the pharmacology? Thank you. Yeah. And I'm available. I understand it was a lot of content. I'm available for Zoom meetings, for guide for the study. And but this all content is important. If you just follow the PowerPoint and the discussion that we had in this 2 hours, and that should be sufficient for you. Thank you, guys. Anna, you have